Welcome to Chapter 1 of the Drug Use and Abuse video. This is the full video of my lecture for the Substance Use Disorder Counseling and Chemical Dependency classes. In this chapter, we examine some basic questions about drug use and abuse. What is a drug? How are drugs classified? When might drug use be good? And when is drug use a problem? If you're a student in one of my classes and have been moved online, I apologize that some of these videos will appear out of order. We'll do the best we can to make sure that you get all the information you need in order to complete your program of education in drug use and counseling. This is Chapter 1 of the Effects of Drugs and Alcohol on the Body and the Brain series. Some of the material here originally appeared on the CounselorSoapbox.com blog, and photos are courtesy of Pixabay and Wikimedia Commons and in the public domain. One question the field of substance use disorder counseling has had to grapple with is the change in thinking between chemical dependency or addiction and the fact that it's possible for substance use disorders to exist along a continuum from mild problems to more severe ones. One of the things we need to ask is, when is drug use good and when is it bad? In the picture on the left, we see people meeting and having lunch and having cocktails with it. That's considered a social use of it and is often thought of in positive terms. The person on the right appears to be guzzling an alcoholic beverage, and this would be problematic use. This brings up the question, is drug use good or bad? And some of that depends on the particular use and your view of it. We have to ask, when is drug use a recreational thing? When is it a bad thing? And when is a particular drug or compound a medication? Sometimes people attempt to self-medicate. That is, they use drugs in a way they weren't designed in order to try to control symptoms of some other issue. For example, many people with depression will drink alcohol. The problem is alcohol is a depressant and will make their depression worse. So we will look at, throughout this series, use of drugs, abuse of drugs, dependency or addiction, and where all of these things may fall on the continuum of a substance use disorder. The question comes up, why do people use drugs? And there are several reasons. It may be medical uses, it may be religious uses, or there are social uses. People may use drugs, particularly alcohol, which is pictured in the photo to the right, to be more social, to feel relaxed, to feel sexier, to relieve boredom, to be more confident, and to become more assertive. Notice that all of the social uses and some of the other medical and religious uses involve taking the drug to shift the way the person feels. Pharmacology and drugs. Pharmacology is the study of drugs. Psychopharmacology is the study of drugs' effect on behavior, and among the things we define as behavior are also thinking and feeling. This chapter, this video, is an overview, and much of this material will be covered again in more detail in specific chapters. What is a drug? For our purposes in this class, we will define it as chemicals or mixtures of chemicals that are not required to maintain health, but which alter functioning or structure. For these purposes, this will exclude food. We know that there's been a lot of controversy about ingredients added to food, such as sugar, that may not be as beneficial as people used to think. But for our purposes in this drug education class, we will exclude those additives to food or anything that is a part of food. In defining what is a drug for this training, this class, we will include alcohol, marijuana, prescription medications, over-the-counter drugs, herbal remedies, home remedies, and the emerging new field of synthetic chemicals that are not yet classified. There are a number of different ways that drugs can be classified, though after we look at this list, I'm going to give you a simplified way of classifying drugs that is of more use to most drug counselors. Drugs could be classified by their origin, such as they came from plants or are synthetics. However, it's important to note there that drugs first discovered as naturally occurring in plants can also sometimes be synthesized in the lab. They could be classified by their principle of use, and that would include such things as, is it for pain or is it for blood pressure, etc. Drugs can be classified by their site of action. Where do they do their work? They can be classified by chemical formula or structure, mechanism of action. Sometimes drugs are classified by street or common names, or by the effects they have on the user. There are three primary types of drugs of abuse: uppers, stimulants; downers, depressants; and all-arounders, those drugs that alter thinking and perception. The uppers, or stimulants, that we will pay attention to in this course include cocaine, amphetamine, and under that heading we include methamphetamine, caffeine, and a little bit about the new emerging field of synthetics that may behave as stimulants. Under the category of downers or depressant drugs, we will talk about the opiates, and those include a lot of different drugs from heroin to morphine to medical use painkillers. We'll talk about alcohol, which is a depressant drug, and things like barbiturates and benzodiazepines, which are often prescription depressant drugs. Under the category all-arounders, drugs that alter perception, we're going to talk about marijuana in a subsequent video. I know there's been a lot of controversy about marijuana as the move has been made to legalize it for various uses, medical or recreational, and a lot of new research is coming in. There's a lot of disagreement about the exact effects, but we are fairly certain that marijuana use alters perception of space and time. PCP certainly does. LSD 25, the kind of LSD most people are familiar with, inhalants, deliriants, and the newer synthetics all alter perception but may not have a principal action as either a stimulant or a depressant. There are two noteworthy exceptions to the idea that all drugs of abuse can be basically classified as stimulants, depressants, or all-arounders who alter perception. Nicotine, and we'll talk about this in the chapter on tobacco, is sometimes a stimulant and sometimes acts as a depressant, and we'll explain that in the video on nicotine, tobacco. This action is referred to as biphasic. Ecstasy, MDMA, and some of the newer synthetics also have dual properties. They can be both a stimulant and a hallucinogen, altering perception. But what we find in working with people with a substance use disorder is typically people are addicted to their drug of choice as either stimulants, depressants, or more rarely we see people whose principal drugs of choice are all deliriants or hallucinogens. The experience of drugs is affected by a combination of factors. Not everyone who takes the same drug gets the same experience. Some of the factors that are involved, and we'll look at many of these in more detail later on, are the drug's chemistry, the dosage of drug taken, the route of administration. A factor called mindset. To briefly explain this, someone goes into the bar and they're happy and they have a drink and they become even more happy. Someone else is angry and upset and goes into the bar and has the same drink and they become more angry and possibly even violent. Setting also is a factor. We'll talk more about this, but many people take an opiate in the hospital for surgery and then go home and they're not addicted. Taking that same dosage amount of a opiate pain-killing drug that's purchased from someone in an alley for recreational use is very likely to lead to an addiction. Someone might have some alcohol in a bar late at night and become frisky. Someone else might have a glass of wine for communion and only be in a religious frame of mind. So the place where it's taken and the mindset both are factors. Many people know about the placebo effect. Even if the drug really isn't doing what you think it's doing, if you believe it, you're more likely to feel that effect. There's also a thing called nocebo, which is that if you expect a drug to have certain side effects or to have allergic reactions to a particular drug, for example, if you think taking a particular medication might cause headaches, you are much more likely to experience headaches, notice them while taking that drug, and attribute those headaches, which otherwise would seem minor, to the drug. Doctors generally don't like to go into a description of all the side effects that are possible for a medication, because the more they tell people about those possible side effects, the more likely that person is to experience those and to think that they're being caused by the drug. Also, while it's not in the textbook we were using for this class, two other things that are important to think about. The level of drugs in the bloodstream. It's not just the dosage that's taken. For example, people take a medication or a drug and then shortly thereafter take another one. How quickly the dosage builds up in the bloodstream and how quickly the liver or kidney remove the drug, those factors result in varying levels of drugs in the blood, and that's very, very important. Also, we'll have to look at the subject of combinations. Sometimes two drugs taken together can have either a larger or a lesser effect than either one would have separately. User characteristics also affect the drug using experience. Some of these overlap with the characteristics I just gave you. But the individual's biology, their gender, for example, some drugs affect women more strongly than men. Their set and setting affect the characteristics. Some people inherently interpret certain drugs in a more positive or negative way than others. Placebo and nocebo effects are important for everyone. And we'll talk in a later video about some special populations and how people of particular ages or ethnicities or in particular situations may have different experiences with the use and abuse of drugs. In all of the classes I teach, we ask people to write papers, and to do that they need to look at research. It's important to look at the research very carefully to know how to evaluate it. One thing that's very important is to look at the sample size. I've read some articles recently, research articles, where the sample size was 5 or 6 people. Now, unless this is an extremely rare problem, any 5 or 6 people grabbed at random are likely not to be representative of the millions of people in our country. It's also important to look at how does the U.S. compare with other countries. When we talk about marijuana use, for example, many people would expect that Jamaicans smoke a lot more marijuana than the United States. In fact, Turns out that the consumption here in the U.S. is higher than Jamaica and most other countries. Those incidents, those levels of use will vary from year to year. Two terms that are especially important to understand: incidents, that's new cases this year, people who were diagnosed or met the criteria to be diagnosed for the first time this year, and prevalence, that is the percentage of the total population which currently or has ever had a diagnosis. Some other drug use issues that we'll need to talk about throughout this series of videos: recreational use of prescribed medication. This has been a large part of fueling the opioid epidemic. Multi-drug use or multiple drug use, sometimes referred to as polysubstance, is increasingly common. The days when we could separate the people who drank alcohol from the people who did heroin from the people who did meth and marijuana into different groups is pretty well gone. If you work in substance abuse treatment these days, what you will find is that most clients are in fact abusing multiple substances. But there is a particular group that we'll talk about later that is called polysubstance abusers, who, rather than having a particular category like stimulants, that's their drug of choice, seem to bounce around to all kinds of different drugs. No one drug may meet criteria, but all of the different drugs that they dabble in from time to time will meet criteria for a substance use disorder. Another thing that's been in the news and a concern for many, many years is use by the young. 18 to 25 age range seems to be the part of the society that uses the most drugs. Recently, however, it's been noticed that use by the elderly, those 65 and above, or the very old even, has increased substantially. So we have to look at those extreme age ends, the very young and the very old. One question that comes up frequently is what amount or what type of drug use is harmful. There's a natural progression which seems to result in the use of drugs. Typically, the pattern begins with experimentation. In my area, in many areas, age of first use is about 8 years of age. Does that shock you? By the end of the 3rd grade, many kids have begun to steal some of mom or dad's cigarettes or bring some alcohol that they got out of dad's liquor cabinet to class and share it with other friends, often out behind the bleachers. It's also recently become common for kids to bring some of their parents' marijuana to school to share with other people. After an initial experimentation, many people drift into a social use. That is, a certain group of kids go out behind the bleachers and smoke cigarettes every day, or have a little bit of alcohol, or smoke marijuana. And as they move through the grades, that social use may stop being lunchtime and become after-school use. The group of friends gets together, let's say every Friday after school, and they all drink together. At that point, it's moved from social use, something they do with their friends, to habitual use. Friday, I drink. And so, one Friday, let's say that one of the dads of this group of friends is taking the kids all to the coast for the weekend. But one kid can't go because his parents won't let him. But it's Friday night, and we drink on Friday night. So what does he do? He steals some alcohol, either at home or from the liquor store, wherever he can get it, and he goes to wherever they usually go, and he drinks, even though he's drinking alone. From habitual use, it often moves to problematic use. More use, going to school drunk, or getting drunk at school, getting suspended or expelled, etc. Drinking and driving is also an example of problematic use. At some point, the person is likely to try to stop. Their problematic use has gotten them into negative consequences. What they find is that when they try to stop, the cravings become so unbearable that they give in and go drink some more or smoke some more just to reduce the cravings. At that point, they have psychological dependency. Eventually, this person may consume enough of the product over a long enough period of time, develop tolerance, and end up with a physical disability. That is, when they try to stop or go without a substance for a period of time, they have physical or emotional withdrawal. We used to call that physical dependency, CD, chemically dependent. Some people continue their drug use even to the point of it being fatal. There are certain combinations, typically alcohol with another central nervous system depressant, which have higher rates of death. Also, over a long period of time, people who use drugs and alcohol can develop specific illnesses that wouldn't have happened or would have been less severe. In addition to all of this, drug use, harmful aspect is medical expenses, and it's important that we not fall into the trap of separating drugs as street drugs and medications as if you have a prescription. Recently, we've seen that many people move from addictions to street drugs to getting prescriptions for something and can become just as dependent and just as many problems from their use of the prescribed medication or abuse of the prescribed medication. There are a number of other drug-connected problems we have to look at throughout this class or this series of videos. One is the connection between drug use and crime. People who do drugs, many types of drugs, engage in crime. One is, since many drugs are illegal, they have to do the crimes in order to get their drugs. They may do crimes while under the influence. They may have to do crimes to pay for the drugs. And many people who use up their money paying for drugs may end up selling some drugs in order to pay for their own habit. We also need to consider the connection between drugs, alcohol, and domestic violence. Our friends who do domestic violence counseling will tell us that, for example, alcohol does not cause domestic violence. There's some truth to that. Every day in America, millions of people go home, have a beer, and most of them do not become domestically violent. But in one study, when a hospital, every time a call came into the police department for a domestic violence, they sent an ambulance nurse out to evaluate the two people. And what they found was that almost 100% of the people who were the perpetrators of violence were under the influence of drugs and alcohol. Further, 50% of the victims of domestic violence were under the influence or had been drinking or using drugs. Sometimes the fight originated over who got the last of the drugs. So while alcohol and some drugs may not cause domestic violence, people who are domestically violent seem to love to do alcohol and drugs. Also connected with drug problems are incarceration. The war on drugs resulted here in California over a 20-year period of an 1,100% increase in the people in prison. This resulted in many families torn apart and growing up with dad off in prison, sometimes mom. There's also a drug-using lifestyle, and living that way also has some risks. There are rip-offs and assaults and robberies and so on that go with living in that lifestyle. Lastly, there are a great many connections between sex and drugs. Some drugs make people more interested in sex, hypersexual. Some people may engage in prostitution in order to get their drugs. Some of the clients I've worked with have never been on a date or never had sex without having drugs or alcohol in their system in order to take the edge off. So as we talk about drug-related problems, sex needs to be one of the things we consider. There's a protocol for diagnosing substance use disorders. One is that the numbers that are assigned to the various drug diagnoses are the ICD, International Classification of Drugs codes. For mental health, many of the people who work in the field were trained using the older DSM-4. And the DSM-4 had one way of looking at it. Recently, the new DSM-5 has been printed, and there's been a shift in our thinking. The DSM-4, and you'll still see lots of literature that uses this terminology, we tried to separate abuse. Are they simply doing drugs occasionally in an abusive, dangerous way? Or dependence. Has this person become chemically dependent or psychologically dependent on their drug of abuse? Research has suggested that there's all kinds of shades along this path, from first experimentation to physical dependence. And as a result, the newer criteria, the DSM-5, lists everything as substance use disorders, and we think of people as falling along that continuum. However, there are separate numbers, codes, or diagnoses for substance use disorder mild, which roughly corresponds with the old abuse, substance disorder moderate, which is a psychological dependency, and substance use disorder severe, which is closer to chemical dependency or physical dependency. The chapter is not just substance or drug-related problems, however. The chapter in the Diagnostic and Statistical Manual is substance use and related disorders. That is the scope of practice for drug and alcohol counselors. In that chapter are also found the behavioral addictions. Currently, in the DSM, the only one we have is pathological gambling. In California, some drug counselors get additional training and do counsel people with a compulsive pathological gambling problem, a gambling addiction. In Nevada, there are two separate licenses for drug counselors versus gambling counselors. Those are within the scope of practice for drug and alcohol counselors here in California, and for master's and PhD leveled counselors and therapists. Being within your scope of practice, however, does not necessarily mean it's within your scope of competency. New counselors should make sure that they get adequate training and adequate supervision by a person who is more experienced and understands these areas. And as a result, they will develop that competency. Otherwise, it's problematic. They shouldn't be working outside their scope of competency. Let's look at the DSM definition of a substance use disorder. I'll use alcohol as an example here, but each category of drug has its own section in the DSM. Assessing is a complicated thing and is beyond our scope of what we're trying to do in this series of videos and classes, but this is a good example. There are 11 different features that are described. One, that the alcohol is taken in larger quantities or over a longer period of time than intended. We can describe this as loss of control. Second, people with a substance use, here alcohol, often have a desire or make efforts to cut down or control their usage. People don't cut down or control usage unless they have a problem with it. Lots of time spent getting it, using it, and recovering from the drug, or in this case, alcohol. Cravings. Cravings is an important feature and was actually added to the definition of substance use disorders relatively recently. Many prescribed medications may have both tolerance and withdrawal. You see those as number 10 and 11. But what makes drugs of abuse and alcohol different is that people who develop a use disorder will have intense cravings. You don't hear about people breaking into pharmacies to steal aspirin or Tylenol, but you do hear about them trying to get alcohol or other drugs. 5, that the use interferes with their roles at work, school, and home. This is occupational functioning, and or social functioning. 6, continued use despite negative consequences. 7, giving up or reducing social, occupational, or recreational activities. 8, using alcohol in this case in hazardous situations. 9, continued use despite knowledge of the problems it is causing. And lastly, 2 of the 3 big factors are tolerance, needing more and more of the substance to get the same effect, or if you use the same amount, getting less and less of an effect, and withdrawal, physical or emotional problems that happen whenever the level in the bloodstream begins to drop. Tolerance, withdrawal, and cravings are the 3 essential characteristics that we think defines addiction. I wanted to say something briefly about the Addiction Severity Index. It's not in most standard substance use disorder counseling books, and certainly rarely covered in graduate programs. But for people, particularly here in California, who work in the drug and alcohol field, every client is usually required to have an Addiction Severity Index evaluation, a type of assessment. And the point there is that in a mental health assessment, a lot of factors are looked at to derive a diagnosis. But in the ASI, the Addiction Severity Index, the goal is to look at all the parts of the person's life and to see how that has been affected by their drug or alcohol use. And so they would look at medical problems, and were those influenced by their substance use, educational problems, employment problems. How else does the client support themselves? Do they sell drugs or prostitution or something illegal? What substances are used and how much? And there's an extensive list that would be assessed. Also, it's common to look at legal status. The ASI looks at parole, probation, open cases, histories of arrests and incarceration. It's also a good idea to assess for family history of substance use and psychiatric issues. Many of these problems, conditions, seem to have an intergenerational transmission process, both learned and possibly genetic. We also look at primary sexual relationships. How many babies, mamas, and daddies are involved? How many marriages or long-term relationships? Who are they currently living with? What are their living arrangements? Do they have housing? If so, is it temporary or is it long-term? Relationships with family and friends. Do they get along with their family? Do they have close friends? The ASI also assesses the history of past treatments for drug and alcohol problems, and there's a page for psychiatric problems, current and past treatments. It's important if you work in the field and you are not a master's level clinician, a licensed person, any drug counselor, if they get any yeses on the psychiatric problems, either current or past, to look carefully at it. If there are current issues in that area, the client should be referred to someone who can diagnose and treat mental illness. Now, that doesn't mean they shouldn't be treated for their substance use disorder. It's often a good practice for the drug counselor to see someone every day or frequently for the drug problem, while the counselor or therapist that is licensed works on the mental health problems that may have existed before or be caused by the substance use. While a few professionals may think in terms of the continuum of substance use disorder, most people think, what is addiction? And there are certain specific characteristics. First, addiction, I would see as a severe substance use disorder. That means it has 3 specific characteristics. Tolerance, needing more and more, or getting less and less of an effect if your dosage stays the same. Withdrawal, which is physical or psychological symptoms when deprived of the drug. Some of the literature calls this the abstinence syndrome. And most importantly, cravings, which trigger the urge to do the drug again. Also, it's important to look at the time spent thinking about drugs, getting the drugs, using, and recovering. All of these factors point towards addiction or the use disorder being on the severe end of the spectrum. Some of the terminology that appears in this section, introductory section, that might be new terms to some of you. One is drug and the definition of that. Two is dosage, routes of administration. We'll talk about that more later. Setting, the placebo and nocebo effects. We talked about evaluating statistics, sample size, but also prevalence and incidence. Polydrug abuse, the DSM Diagnostic and Statistical Manual. Tolerance, withdrawal, also called abstinence syndrome. Talked a little bit about the distinction between being chemically dependent and psychological dependency, and about the importance of attending to cravings in determining how severe the use disorder might be and how to proceed with treatment. Other terms you should be aware of and understand: addiction, drug abuse, drug effects. We mentioned briefly over-the-counter drugs that can be purchased legally without a prescription. There'll be an entire video later in this series on over-the-counter drugs. We talked about pharmacology, about psychoactive drugs, a little bit about psychology, and about psychopharmacology. While this video has talked about a number of different factors, what are the big things that you really should understand if you want to understand substance use disorders or to work in this field? First is, what is a drug? You need a definition. And you should have an understanding of the three basic types of drugs of abuse: uppers, stimulants; downers, depressants; and all-arounders that alter perception. You should also be aware that there are two exceptions to this, and we'll have to look at these two exceptions in separate videos in much more detail. One is nicotine, and the other is ecstasy. And you should be aware that there are a variety of factors which affect the drug using experience. In looking at research, you need to know how to evaluate the research and to look at statistics, sample size, and incidence and prevalence. You need to know what those two words mean. And lastly, students in this field should understand that the DSM-5, the most recent Diagnostic and Statistical Manual, is the book which includes a chapter on substance use disorders. That's the scope of practice for drug and alcohol counselors. But that chapter also provides extensive criteria for more advanced licensed counselors and therapists to use in diagnosing the specific illness that the client would have.